Welcome to the Docs Who Lift podcast, where we distill and simplify the complexities of a healthy lifestyle, exercise, medicine, and weight loss. We're excited to bring you a podcast that's a prescription for clinical practice, scientific recommendations, and just real life. This is the Docs Who Lift podcast.
Hey, and welcome back to the Docs Who Lift podcast. I'm your host, Dr. Spencer Nadolski, and co-host Dr. Carl Nadolski Jr. is with us, and we have our special guest back, Dr. McGowan, super GI doctor extraordinaire, coming back to discuss and a fellow doc who lifts as well. Coming back to discuss some cool findings, and he's actually famous. I was getting followers were sending me articles like, "Did you see this?" I'm like, "That's my boy. I know that guy. It's my boy right there." Some cool find. I'm going to let you describe it so I don't mess it up. But new cool abstract that you just presented. The full manuscript and every study is under review, but we're going to talk about how it's probably going to be practice changing here soon. So tell us what happened. What actually got published?
And where did you present this? Digestive Disease Week. Huh?
Digestive Disease Week in Washington, D.C. just a couple weeks ago. That's the largest GI gastroenterology conference in the world. Tens of thousands of
no
GI
big deal
docs and others
no
come. Yeah, big conference. And so I presented this first in human study. So that's really what we're going to talk about today. And I do think it is a potential game changer in the field. It's a new treatment path. I mean, how often do we encounter a new treatment for obesity? Not too often. We've seen the disruptive medications recently, but from a procedural standpoint, not that many. So this is a new direction. And I can walk you through the basics, but in its simplest concept, the question we asked is, can we reduce hunger endoscopically? I mean, that's really important. All the procedures we have currently
tell
are
everyone a little background on, because I know, like you said, it was the first in human study where you're talking about ghrelin. So let's make sure everyone knows what the heck that is. And then maybe some of the animal stuff that maybe you did, or I don't know.
And for those listening, we also have a podcast with him going over all the procedures that are done endoscopically, going through the mouth, through the esophagus, and to the stomach and intestine. So go do a review if you haven't listened to Dr. McGowan in the past, but this is kind of a follow-up to that.
And maybe reviewed, I don't know, we've talked a lot about the different hormones that regulate our body's appetite, metabolism, et cetera. And, I don't know that we've talked a ton about ghrelin, the hunger hormone, that it's actually a growth hormone, secretagogue, we call it. It stimulates growth hormone in my world, but, it comes from the stomach, and it's our main hunger hormone. It increases hunger, increases calorie intake, goes up. It seems to be increased in people with obesity, and seems to go up when people lose weight. And so we don't have any medications that deal with this. A lot of our medications we talk about a lot are, other gut hormones that work on satiety.
There have been some vaccines, I believe, in the past. I don't know if they actually worked in animal models, but
nothing really panned out.
Yeah, nothing panned out.
That's a good overview, Carl. Ghrelin's it's the only known orexigenic hormone, which is appetite stimulating hormone in the body. Everything else is anorexigenic. We talk about GLP. You boost that to suppress appetite. Leptin, most people are familiar with that. All of these other pathways are suppressing appetite. Ghrelin is boosting it. So you could imagine that if we can counteract that in some way, it's pretty important. But there's no pharmaceutical treatment for that can achieve that. The only way to reduce ghrelin directly is to surgically remove the part of the stomach that produces it. And that's the key point. It's produced within the stomach, actually in the innermost lining, the mucosal lining of the stomach. So if you cut away stomach tissue, ghrelin goes down. It's one of the reasons that patients lose significant weight with a vertical sleeve gastrectomy. You could bypass that area with a gastric bypass. So that's one of the contributing factors. Maybe not the most important, but it's one of them. And if you talk to patients who have had bariatric surgery, they're not very hungry for quite a long time. That's that ghrelin effect. But there's no other way to alter that yet. And so that's what we were trying to investigate. Ghrelin works. It is produced by the stomach lining. It travels to the brain. to the arcuate nucleus in the hypothalamus and stimulates that area, and that makes us hungry. And so, and that happens when your stomach empties. Empty stomach, ghrelin goes up, brain says, time to eat. The problem is that as you're losing weight, it also increases further. So you're dieting, you're working so hard to lose weight, and you're just getting hungrier and hungrier and hungrier. And that is that ghrelin effect, amongst others.
We call it
and
hangry
it's really hard.
hormone.
Hangry hormone. It's really hard to lose weight if you're starving. And so that's what we were looking to try to address. Now, the last time we met, we talked about the endoscopic sleeve gastroplasty, or ESG, which is a very well-established endoscopic bariatric procedure. We make the stomach smaller internally. It works. We know it's effective. It's clinically proven. The weight loss is very significant. Doesn't really turn off appetite. It's one of the reasons the weight loss is a bit less than surgery. Patients have less hunger, but not for as long as you see with a surgical sleeve. And I do think it definitely is related to ghrelin and the impact of the fundus. Mm-hmm. So that's what we were looking to understand. And there is a foundation of science backing this up as far as the technique of gastric mucosal ablation. So this endoscopic technique, and I can walk you through how we do it, but there are early animals, small rodent studies, animal studies, preclinical data, but we were the first to really try this in a human. And it was a big leap. Can we do this safely? Can we treat obesity with these techniques? And then what is that actual impact? So we had to study this by looking at it in many different directions, not just doing a procedure and seeing if people lose weight. That's not good enough. So this was really a mechanistic study and a safety study at its foundation.
Mm-hmm. Yeah, walk us through it. Let's hear it.
All right. So here's what we did. So let's just talk about the technology a little bit, because that's really how we can conduct this. All of this is endoscopic. So as we talked about last time, gastroenterologists basically just plumbers. So we're going down a pipe, the esophagus, into the stomach. And then as we enter the stomach with an endoscope, if we turn left and look upward, is what we're really doing. That's the fundus. So it's kind of the cap on the stomach, even though fundus means bottom. But it's really the top if you're standing upright. It's the top of the stomach. So we can drive our endoscope to the top of the stomach, and we're seeing that lining of the stomach. We can access it directly. So then the question is, how can we ablate or thermally treat the lining? So we're using a device. Burn it. We're burning it.
Yeah.
Which you've done. Who did you do this in animals, or was it other people? And you were like, "Hey, we can do this in humans." And I'm almost surprised it's taken this long to do this, because
there's a couple reasons.
It almost seems obvious to us non-surgical people.
Yeah, there's many reasons why it has taken this long. So collaborators, colleagues of mine at Johns Hopkins and Mayo Clinic, Vivek Kumbhari in particular, this was the foundation of his PhD, and did a lot of the early research, as well as the device company Irby, who makes this device, has really been investigating this. So over this roughly 10-year period. So there were a lot of questions, and we had to be careful. You can't just go in and burn the stomach.
Right.
And if you think about the fundus, it's about 2 millimeters thick. You can burn a hole right through that if you aren't careful. We don't want to do that. Now, we do use this technique of argon plasma coagulation, or APC, to treat small areas, small lesions in the digestive tract. So that itself is not new, but we're treating millimeter-sized areas, maybe slightly larger. You have an abnormal blood vessel, maybe you want to ablate it to get rid of it. But the idea of burning a really large area had never been done. So some of it was, is it safe? Others questions were, what are the settings we need to use to do this safely, where we're not burning into deeper layers? Look, we only care about the mucosa. That's where that hunger hormone is produced. We don't want to damage the submucosa, the muscularis layer, burn to the serosa. That's a real problem. So those were the preclinical studies that helped us understand the wattage that we need to use, all these settings. Okay, so that's important. Next, you can't just apply heat directly. We have to protect the underlying structures. So we're using a technique, this is really technical, but it's called hybrid APC. So we're not just burning, we're first lifting. So it's a really advanced device. The probe, we press against the mucosa without any needle. It applies high pressure saline that creates a submucosal cushion. So we're separating the layers away. It looks like a pillow, basically, of fluid. And so then when we apply heat, that heat is not transmitting to deeper layers. So it's a really advanced technique. It's a step beyond the normal tools or techniques we use. Okay, so all that had to be demonstrated. And then you had to find someone crazy enough to try this, which is where I came into the picture. Right. because people said, well, it's too dangerous. It's not going to work. You can't stop ghrelin. It's never going to work. With anything new, there's going to be doubters. And of course, we have to be cautious. So we had to set this up as a very rigorous clinical trial, IRB approved, registered clinical trial. Amazing patients who took the leap with us. We had 10 patients in this initial study. And then we had to study it in every way possible. So again, not just weight. There are too many variables that affect weight. You can't take 10 patients and determine much at all. I mean, just being in a study, you can lose weight via the Hawthorne effect. So not just weight, not just ghrelin. And I think we'll get to this. There's way more to this story than ghrelin. But we did need to measure that. And that is the first barrier. How do you measure ghrelin? It's really, really challenging. You can't just go to LabCorp and get a ghrelin level. So it took us quite a long time to find a lab that does this. There's like one lab in the country, how to ship the samples and how to process everything effectively, because we need accurate data. And then we had to look at other parameters. So how does this affect satiety? How does this affect capacity? There's more than ghrelin occurring, as we learned in the study. There's remodeling that occurs to the fundus, and that has other impacts. How do patients describe their hunger? We need validated questionnaires, right? So we had to utilize those in the study. So we tried to look at this at many different angles so that we could emerge from this knowing that it's safe or not, that it works or not, and what does it actually do? So that was the foundation of the study.
So I guess I'm interested in, like you said, getting patients to do it, to try it. So there had to be, and the doubters and the people worried about safety, obviously that's why the animal studies were done, right? To kind of say, hey, this is safe and seemingly effective in animals, so now we're going to maybe take that step. So, I mean, it's like, I guess, how were you able to sort of communicate that? Obviously, those somewhat safety benefit in data from the animals to the potential patients who ended up doing it.
Right. So we have to talk through the evidence that we have. So what do we know from animal studies? There were some preclinical studies using ex vivo human stomach tissue to understand how this works. Okay, so not live humans per se. There was also one small study that took patients undergoing a traditional sleeve gastrectomy, treated focal areas in the resected zone, then it was removed and looked under the microscope. So that's extremely helpful to understand what's going on at a microscopic level. I felt strongly, and we felt this can be done very safely, but we didn't really know what the recovery would be like. We of course, didn't know what the impact would be, but it was certainly a leap. But how did we get patients to agree to this? Well, of course, it's a clinical trial. We're not coercing anybody. We lay out the risks and the benefits. What I told every patient was, this might do absolutely nothing for you. We honestly don't know. But what it speaks to is the desperation, like we've talked about before. People need help losing weight. They will try anything. And the theory, the hypothesis here is legitimate, right? I mean, we felt strongly that we're targeting the right areas. We know that ghrelin is really important. We really do think this could work. Let's give it a try. Now, we had to do it ethically. That's why it has to be IRB approved. Now, all those safety measures have to be in place. And then we see the patients numerous times throughout the study and do all these different measures and assessments. So,
but the animal studies must have been pretty reassuring. I mean, I guess that's what I'm getting at. Like, you know, like if I were going to volunteer for a study, I'd be like, oh, that looked pretty darn good in whatever animal that's similar to us.
A lot of the early studies were trying to recapitulate a sleeve gastrectomy and really focused on that greater curve, the body of the stomach. Our goal was to target the fundus. We always felt the fundus was more important because not just ghrelin, but you think about how the fundus affects satiety. It's actually probably the most important part of the stomach. When we eat, that fundus expands when it reaches capacity. That's what signals the brain to recognize fullness. And so that really felt like the better target here, rather than just trying to ablate the body of the stomach to make it narrow. Like we've done that. We can do that with the endoscopic sleeve. Let's see what we can do with the fundus and those hormonal pathways. So patients agreed to be in the study, and we did the first case. I should mention that I'm sure there's gastroenterologists listening to this. The technicalities are not to be underestimated. It's a really challenging procedure. We're working backwards. So the scope is candy caned. We're looking completely backwards. This little probe that we use is 2 millimeters in size. We're ablating a multi-centimeter area, basically 1 millimeter at a time. and the stomach's dynamic during the procedure. Patients are breathing. It's right under the diaphragm. Everything's moving, and the probe has to be exactly a millimeter or so from the mucosa to conduct this electrical current. So it's really technically challenging. The first cases took something like 2 hours. Now we've worked out the kinks and have treated many, many more patients in other studies. And it's now, I can perform it, and my colleagues in our center can perform it in about 30 to 45 minutes. Wow. So we're much more efficient. But the first case took forever, and it looks frankly hideous when you're doing this. This looks like a burn of the stomach lining. I mean, I definitely said to my team, let's get a hospital bed ready because this patient's getting direct admitted. They're going to wake up in agony. And then we woke them up and they had no pain. And that was pretty amazing. So that was step one. It can be done, and it is not painful, and it can be done safely. So we felt really good about that. And then it was just following those patients forward to see what it actually accomplished.
Are you doing the sleeve with it or just the ablation?
So this study was just ablation.
Okay.
We had to separate it out, right, to understand what the ablation does. And so we tracked everything for 6 months. We have a separate study that is looking at combination endoscopic sleeve with fundus ablation. I think that's the greatest implementation of this technique, but those studies are still ongoing, but clearly boosts the weight loss from an endoscopic sleeve. And that hunger component is very significant for patients.
Yeah, it'll be, easier for like RCTs because you could do like, well, this person we ablated, this person not, and they don't even know. You could just
easy.
Make it. Yeah, you won't be blinded, but
easy to perform. It can be a crossover study. Patients who don't have ablation cross over in a year. You can see the impact there. It's very, very easy to study. But I can tell you that in clinical practice, in the patients in these early studies, it's really compelling. There's really no question it has an impact. But then if we just focus on the fundus ablation, though, what did we show? And I think it's probably worth reviewing the results. I will say this is why we have to do studies, because first the patients had no pain, and I'm like, you almost want people to like feel something, right? And they didn't generally. And then it takes time for the impact. We're not cutting that stomach away. The tissue's going through a healing process and then a remodeling process. And so it's almost a delayed effect. What we learned is it takes about 2 months for the full impact. So a month in, I was thinking this isn't doing anything, and then we realized, oh, wait a minute. Then patients are reporting, I'm way less hungry now. Month 2, month 3, my capacity is less. Month 2, month 3. This is fascinating. So what we found is this. We treated patients, their ghrelin levels decreased by about 45% just by ablating the fundus. That is identical to most studies of a vertical sleeve gastrectomy. It's a pretty big deal. So that reached its nadir at about 2 to 3 months and stayed flat out to 6 months. Okay, so that's good. We asked patients if they're hungry, how their cravings are, using these standard inventories. One of them is called the Daily Eats questionnaire, and that significantly statistically reduced hunger and cravings. We asked them if they have confidence to resist overeating. That's a really important parameter, significant increase. And then we did another test, which I think is the most important thing. We had to measure satiety, capacity. And so we had them, we did a test called a nutrient drink test. And these poor patients, they really were invested in this process because we asked them to drink Ensure until they can't drink anymore. So we have a measurement of capacity, and they've had to do this so many times throughout the study. But what we found is at baseline, before the procedure, they can drink around 800 plus mLs. It's like 4 bottles of Ensure. It sounds about right. And then you're stuffed. By 6 months, that was also reduced by 42%.
Wow. Just
by treating the fundus. We haven't altered the rest of the stomach. Now, that's really interesting. So that speaks to the accommodation and that physiology of the fundus. And then at 6 months, we did endoscopies on everybody. And this was really eye-opening. So I mentioned how we drive the endoscope into a normal stomach and look left, and it's a big, capacious, expansive fundus. That's what we normally see. The first case, I drove the endoscope in, and turned left, and it hit a wall.
Wow.
The fundus basically contracted down to nothing. It really was amazing. So that's the application of heat to tissue. It contracts. And so what we showed under the microscope is that the mucosal lining fibroses, and it's really stiff. And also under the microscope, the ghrelin cells aren't there in the same frequency. They're more than half reduction in ghrelin producing cells. So those are all the findings from this study. after that 6-month period.
So it all makes sense. And the average was about 8% weight reduction, right? Obviously, there was no placebo or sham group, but that's
Right.
that's very meaningful to us in this regard. How was so and this is why huge studies with huge numbers are needed for, like, say, medicines, because everyone's different, right? So how much variability? Like if you did like a waterfall plot, like the 10 different people, how much variation was there amongst those individuals in the study?
Yeah, it's a good point. And that's why I look at this more about mechanism, proof of concept, because if you look at 10 patients, it's a wide variability in terms of weight loss. And I know all these patients so well, and I know all the things that are happening in their lives, and you can imagine how that affects everything, not just ghrelin capacity, but wide range. So the average was about 8%, which is clinically significant. Some patients lost less than 5%. The majority, so more than half, lost 10% or more, actually. And then the maximum was 17% weight loss at 6 months. Now, that's really significant. So then the question is, what happens when we treat 100 patients, 1,000 patients? Then we'll know what the actual means are, and we can have a better sense of it. My feeling is it's around 10 to 15% if this tracks forward for a year or more.
What about any concerns about gastric cancer after modifying those cells? Because, I don't know, you see people drinking hot, I don't know, whatever. You see those epidemiological studies of people who drink more hot tea, have more XYZ and whatever. Anything? And is it, I don't know about the fundus. I can't remember.
Is there a hypothetical concern based upon any type of
gastric
science
cancer
data that we have?
It's probably the opposite. I mean, we actually use these techniques to eradicate precancerous or cancerous tissue. It's a fair question, but if you look at the histological level, the tissue is replaced by fibrotic tissue. It's unlikely to think of how that would then transform into something malignant. So I don't think so. There's no real basis for that, especially in our world of GI when we treat things, when we ablate tissue. Again, we're using it to reduce that rather than increase risk.
Okay. What about
probably
reflux? Are they having less now because of... I don't even know what the fundus...
I guess any other findings, so any other things. I mean, you guys looked into all sorts of stuff, right? So...
looked at a lot of things. So that gets to the adverse events, and that's important. So number one, there were no serious adverse events in the study. That's great. We know that the stomach basically ulcerates after this and then has to heal. So we need to protect that area with medications. We reduce acid, put them on proton pump inhibitors. So there is a theoretical risk of ulceration. We didn't see it in the study, but I will mention that. That's probably my top concern until things heal. What we saw is gas, bloating, cramping, nausea. These were self-limited symptoms. We saw, this is interesting, it's reported as an adverse event, but aversion to savory and sweet foods.
Oh, that was an adverse event? Wow.
Well, they didn't have it at baseline, but I would look at that as obviously an advantage.
Yeah.
And good. So that's what we heard from patients is much akin to what we hear with GLPs, which is just turning down that constant hunger noise and having more control over eating. But as far as reflux, Spencer, I will mention that's a concern that we had going into this. So we're removing that fundus cap, that reservoir, which we had talked about before, maybe as an advantage, like in the endoscopic sleeve, while we don't see reflux. We did not see any acid reflux. In fact, patients with existing acid reflux had improvement. So maybe that's driven by weight loss, but we did not see an increase. And we haven't seen it in any of other studies either. So that's a positive.
Well, I was just going to ask, I can't remember my basic physiology of the stomach, but like the acid producing cells are less so up in or more so up in the fundus versus the...
Oh, right. I see what you're saying. Yeah, I mean, the stomach's still churning out the same amount of acid. The issue is if we're changing the anatomy, are we going to somehow facilitate more reflux? But again, we're not really seeing that yet.
So it could be less acid maybe then by burning some of those cells? Yeah, I don't know. I'm just spitballing. I don't know what the hell I'm talking about.
He's really making some shit up.
No, but like if I'm just trying to think of like if there's fewer acid producing cells.
Probably not. But we don't have to go further down that.
Interesting. Yeah.
Speaking of that, what was the post procedural like dietary protocol that you did?
Liquid diet.
Very minimal post-procedure transition. We did liquids for, I think, a few days. We made it really brief, a few days, and then transitioned through soft foods and then to regular food. We didn't want to put someone in liquids for 6 weeks and they lose weight because of that. Like that wouldn't be appropriate. Same thing they worked with dietitians, but it was a very mild, minimal lifestyle intervention because we didn't want to have that drive the weight loss. What we now know is it's probably better to stay on liquids longer after these techniques. As soon as we introduce food into the stomach, it is going to churn out more acid. It's going to produce more pepsin. We want to protect that area, so we probably need to extend the liquid phase a bit. That's hypothetical, but something that we've been doing more recently.
Did you measure any other hormones? And you probably know some of which I'm getting at, but...
No, yeah, we didn't look at anything further upstream, which would be really interesting. PYY and things like that, or neuropeptide Y, I should say. We didn't look at any of that. We looked at insulin levels, not really directly relevant. It's so incredibly difficult, expensive, and cumbersome to measure hormones. We restricted it to ghrelin in this case.
What about, and actually, you know what, I suppose since we're talking about that and we have other studies that have reduced ghrelin, obviously, in the surgical realm, is there, because I don't know this off the top of my head and I should, is there any impact on growth hormone and IGF-1?
Yeah, I don't have an answer to that. It's a good question. There are theoretical, there are other areas in which ghrelin might, other pathways, other areas, other impacts. I think those are much less proven if you look at it. Clearly, it's primarily drives appetite. It's orexigenic primarily. I think another point is that we're not eliminating it completely, right? So we're reducing it by maybe half. There's still ghrelin produced elsewhere in the stomach, somewhat in the small intestine, but the other areas may compensate over time as well. But are there other implications? That has not been shown. I have not seen that in the surgical literature.
Did you do the whole acylated versus non-acylated or deacylated ghrelin? Did you get into that with the labs, like which one to measure and all that? I don't know if the labs even talked about that, but
I'll be honest, no, I don't believe that was mentioned. It does have to, so the lab that we worked with was called Inner Sciences, and it has to be done perfectly. You have to fasting level, 10 to 12 hour fast, first thing in the morning. We had patients do it at exactly the same time each time they had the measurement. It has to be centrifuged, and frozen, shipped out on dry ice, this whole process. So we have accurate data. We know it's accurate because it was so strongly statistically significant. I mean, this is not by chance. If you look at the p-values, actually for all of these outcomes, they're tiny, less than 0.0005 or whatever. And that's hard to achieve in a 10 patient study. So I can confidently say that we've proven the mechanism. And then really it's about what are the next steps and where can we take this? And that's maybe even more exciting. So we're combining it with endoscopic sleeve. We think it may have a role as a transitional treatment for patients who can no longer stay on GLP meds or don't want to. I mean, think about that. It suppresses hunger, helps with capacity. So that might be an option for those, like in our state in North Carolina, 25,000 people just lost coverage for GLP meds from the state health plan. What are they doing, right? What can we offer? They may not want to take the leap to something much more invasive, but something like this could be a transitional treatment. So there's a lot of areas where we could take this.
So you're going to have to get FDA approval for because you can't just go offer this to your patients now, or can you?
Well, technically the device is, it's an FDA approved device that we use and is essentially on label. But if we're talking down the line about insurance coverage, things like that, that would need to be an FDA approved procedure. That's a much more complex process.
So how much would this cost if somebody be like, you know what, I'm good with this mechanistic study, I want to go get this by Dr. McGowan. How much would that cost?
Yeah. So, and we are offering, so we have, our clinical trials have completed. We have registries now where we're continuing to track patients and enroll them in ongoing registries. So this is something that can be available. Pricing wise, it's around $6,500. I mean, I think that covers
anesthesia and your
everything,
room costs, everything.
Plus follow up. Yeah. We don't know how this will play out long-term in terms of price point. I also want to be really cautious. And again, knowing there are gastroenterologists listening to this, don't try this at home yet. Okay. This is a first in human study.
Yeah. Very experimental.
We're all very optimistic. But there are so many complexities to this, and it can be incredibly dangerous if you aren't careful. And there's probably 20 steps that we take during a procedure to ensure safety. So I think we have to fine tune further the techniques until we can really standardize it before it's ready for widespread adoption. But from a cost perspective, I mean, it should be significantly less than, say, a year of treatment with a medication, significantly less than surgery. Obviously, recovery is almost nothing. I mean, maybe a day or two. So there's little downtime. So all of those are advantages. And again, the safety appears quite good at this time.
When will your newer studies start coming out?
Yeah, so the manuscript for the fundus ablation study should be out very, very soon. It's currently under review. By the fall or end of the year, we'll be releasing the initial combined fundus ablation with ESG data. So you can look for that by end of year. And then the next step would be the larger and longer term follow-up of fundus ablation to see what is that actual weight loss average, and what's the impact on larger numbers of patients. So those are
and then RCT of like comparing.
That would be the goal.
Cool.
Yeah, we were just talking about that with our research team this morning about that type of randomized crossover study.
Very cool. Anything else? What do you want to ask?
Well, while I was asking that, we didn't quite know the answer. I did a quick little literature search, and it's interesting. I don't see a lot of this stuff when I search it up, but the whole growth hormone after gastric sleeve thing. But I found, I think this was a retrospective. No, this was actually a trial. So in 33 people, they did sleeve gastrectomy. And this is interesting to me. So the systemic growth hormone actually increased after the surgery. There's no change in the IGF-1. So for anybody listening, growth hormone is very pulsatile, kind of all over the place from your pituitary. We actually don't measure that by itself when we're looking for, in my world, people with acromegaly, which is growth hormone producing tumors, or if they have growth hormone deficiency because of whatever reason in the pituitary, we check the insulin-like growth factor 1 because it's a much more stable protein that's made by the liver. So really that's technically probably more important to me, but it's interesting that the growth hormone went up despite reducing the ghrelin, and really without any change in insulin-like growth factors. So I don't know. I think I'm going to have to look more into that. I feel like I'm sure we've read it and talked about it in the past, maybe when I was in fellowship, but that's actually a little interesting to me.
Yeah,
probably to nobody else listening.
I'll let you,
Nobody cares.
I'm going to let you sort that out, definitely. But a sleeve is way more complex and affecting so many more pathways. It's hard to isolate that impact.
Sure.
But what I tell patients is we know that this is not a lifelong reduction. I mean, boy, we'd love for it to be a lifelong reduction in ghrelin, but the body is too smart. It's going to produce ghrelin elsewhere. So if there were any negative effect, I would have to think it's minimal, because down the line, whenever that is, 1, 2, 3 years down the line, as things come back, ghrelin would probably return to normal at that point.
Very interesting.
Yeah,
cool. Well, again, where can our people find you? TrueU is your clinic, but what about online? What website?
Yeah, you can come straight to our website, trueuweightloss.com. You can find me there or elsewhere on social media. But yeah, check out trueuweightloss.com. We do have information on this procedure, on our ongoing clinical trials, and you can check that out.
Very cool.
Yeah,
thanks again
so
for
much,
coming on.
Blake.
We'll have you on when the new studies come out
Keeping
too.
our listeners on the leading edge of procedural medicine.
Cool to hear. All right, here's our outro.
This podcast is for entertainment and education and information purposes only. Remember, the physicians on this podcast are not your physician. It should not be considered professional or personalized medical advice. It should not be used to replace speaking with your physician or medical professional to discuss your specific health concerns. The topics discussed should not be used solely to diagnose or treat any condition. As a result, we are not responsible for any unwanted medical outcomes. The views and opinions discussed are of those of the host only and do not represent those of any other entities.